morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to yet another episode of ACNS webinars. The speaker for the first session of today's webinar is our honored guest from the USA, Professor Tomita. Professor Tomita is a consultant neurosurgeon at the Ann and Robert H. Lurie Children's Hospital, Chicago, Illinois. Professor Tomita was a past president of the ISPN, and he was also a member of various societies like ANS, CNS, WFNS, and ASPN. His primary focus of interest is in pediatric brain tumor surgery. He has dedicated his life for the treatment of pediatric brain tumors. He is a noted author with over 185 articles in refereed journals, of which 62% are related to CNS tumors. He has also written 38 book chapters covering the subjects of human brain tumors such as head trauma, neural tube defects, tethered cord, vascular malformations, and medical education. We are extremely honored to have him today at our webinars, and today we will be talking about pineal region tumors in infants and children. The speaker for the second session of today is our honored guest, who is originally hails from Albania, but now in Canada, Professor Arion Musabiliu. Professor Arion has special interest in the development of neurosurgery in the LMICs. He was a past fellow at the Fujita Health University, Japan. He is one of the pioneers of telemedicine in Albania, and his research interests are focused upon brain tumor and metastatic biology. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars, and today we'll be talking about melanoma brain metastasis from skin to brain. The chair for the first session of today is our distinguished faculty from Japan, Professor Nobuhito Morita. Professor Morita is the Associate Professor, Director, Division of Pediatric Neurosurgery, Kitasato University School of Medicine, Sagamihara, Japan. Professor Morita specializes in the field of pediatric neurosurgery, functional neurosurgery, intraoperative neurophysiology. He is an executive board member of the Japanese Society of Pediatric Neurosurgery, Pediatric Neurology, Spina Bifida Association, and Asia Australasia Society of Pediatric Neurosurgery. He is an integral part of the ISPN and is also on the editorial board of the Chinese nervous system. He is a noted author who has published several manuscripts in various period journals and book chapters. We are extremely thankful to him for accepting an invitation to chair the session of Professor Tadanori Tomita. The chair for the second session of today is our distinguished faculty from the USA, Professor Alireza Manzouri. Professor Manzouri is an assistant professor in the Department of Neurosurgery at the Penn State Cancer Institute, Pennsylvania, USA. His clinical interests are focused upon brain cancer trials, surgery of brain tumors, and epilepsy surgery. His literary contribution sums up in scores of international publications and book chapters. We are extremely thankful to him for accepting an invitation to chair the session of Professor Arion Musabiliu. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Lubun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Nobuhito Morita.
Thank you. It's my great honor to chair Professor Tomita's lecture. And as you know, Professor Tomita is originally from Japan and stayed in the United States for a long time. And today he is going to talk about pineal region tumors. Pineal region tumor in Japan is also a synonym of the germ cell tumor. And Japan Brain Tumor Society published this. This is Japan's guideline for the treatment algorithm of central nervous system primary germ cell tumor. And for germ cell tumor suspected, tumor marker was checked, and with the Hydrocephalus or without Hydrocephalus, we somehow changed the treatment strategy, and the tumor marker, and we are generally do the biopsy in all cases. And if the diagnosis melanoma, chemo and radiotherapy follows. And if the tumor is non-geminomatous germ cell tumor, then mature teratoma or other non-geminomatous germ cell tumors, the treatment is the chemo and radiation and the surgery. And these follows after the chemo and radiotherapy, we go on to the surgery. And so something we have to think about the, is a pathological diagnosis necessary for central nervous system germ cell tumor? And is radical resection of germinoma necessary? Is surgical removal necessary for non-geminomatous germ cell tumor? And this is a recommendation in Japanese Society of Brain Tumor. But probably Professor Tomita will tell us more detail about these issues. And I'm expecting his lecture. Thank you very much.
Thank you very much, Dr. Moroda. It's nice seeing you. And it's a great pleasure to be here. Good morning from Chicago, and good afternoon or good evening, wherever you may be. Now I'm talking about this pediatric pineal region tumors and management strategies. And I have done this surgical approach using posterior interhemispheric approach, which is probably you call occipital transcendental approach. And I just like to share my experience with you. For instance, this patient, 4-year-old boy, presented with headaches, and initial CAT scan showed, you can see the Pineal Calcification and Hydrocephalus. So I did the ETB, and MRI did not disclose any specific reason why he has hydrocephalus, but ETB was done. That was in April. And 3 months after ETB, suddenly developed precocious puberty, but his headache's totally gone. And at that time, the beta ACG was CSF, because I usually place on my reservoir after the ETB, and the CSF was aspirated. That showed increased CSF beta ACG, but negative AFP. And you can see a very distinct mass in the southern ventricle to a pineal location. And well, we concluded this is germ cell tumor, and let's treat with chemo. And chemotherapy was started with carbo, ifosfamide, and BP16. And the tumor appears to be still there, but reduced in size, but beta ACG dropped to nearly 0. But because of the presence of persistent mass, I did occipital transcendental approach, and this cystic mass was removed because interest of the time, just keep moving. So this turned out to be the cystic mature teratoma, and we concluded this one as a mixed germ cell tumor. And this patient was treated with subsequent radiation treatment, and then has been free from the disease nearly 10 years. The another one is here like this. This is a 5-year-old boy with 6 weeks history of headaches and double vision. And you can see that the CAT scans outside a hospital showed some speck of calcium in that, and MR showed a mass in a pineal location. So this was also operated on the same approach, and you can see this surgical, you can see some flake of the calcium from this, the quite suckable mass. And this turned out to be the pineal blastoma, and this also resected well. And his pineal syndrome is still there over many years, but otherwise he has been quite functional after oncological treatment. Now, this is another example of different type of the pineal region mass. This is a 5-year-old boy with gait ataxia, and 1 month he has some headaches, and finally CAT scan was done by a local physician, and that showed the mass in the posterior south ventricle. But this mass showed very peculiar the appearance of sagittal image. It's not only extending to the pineal system, but toward the fourth ventricle. And this tumor was resected. So this is a tentorial section of the sagittal video, and directly underneath of the tentorial opening, there is a mass indeed. And this is much benign looking, and you can see the vein of Galen right over there. And this tumor was under the surgical microscope resected, and this turned out to be the benign JPA arising from the superior medullary biram. And this patient did very, very well after the tumor resection. And how about this one? This is one of the oldest boy, a 17-year-old boy with a known neurofibromatosis type 1. And he suddenly developed hydrocephalus, and he was shunted at the outlying hospital, and then he came to see me. And this is a mass and posterior parietal, posterior pineal location, and extending more or less a brain stem at the midbrain level, and it's extending from so-called pineal cistern to the tegmentum of the midbrain. And this is also approached through the same posterior interhemispheric transtentorial approach. This is after tentorial section is done. This is a bulgy structure of what appears to be the tegmentum or tectum plate, but with approach slightly sideways, and then take this tumor out. Now, this is the patient who had gross total resection was attained through this approach, transtentorial approach. And this looking at this anatomy here is quite interesting. What the true origin of the tumor is? There must be the brain stem sparing that quadrigeminal plates, yet you can see the entry site right over here. But this patient showed a quite intact post-operative course. We don't see any ocular or auditory dysfunctions. And 5 years later, this tumor resected cavity now collapsed and pretty normal looking brain stem. So in this pineal location, which expand from posterior south ventricle to the quadrigeminal plate, or the vertically corpus callosum to upper posterior fossa. And tumor origin, obviously, the first and most important one is pineal gland, but I use the word parapineal or extrapineal structures, such as the brain stem that is midbrain, tectum, cerebral peduncle, and posterior commissure, and posterior thalamus, superior medullary biram, superior cerebellar peduncle, superior vermis, and a splenium and medial occipital lobe, which is just side wall of the mass, pineal location. Now, those patients, the tumors can extend exophytically to the CSF space to the south ventricle anteriorly, or quadrigeminal system posterior, or sometimes go down to the fourth ventricle as well. Now, the tumor from the pineal gland is probably, everybody knows about this. The most important one is probably germ cell tumors, like Dr. Morota mentioned. And another one is the pineal or parenchymal tumors. And these two quite distinct tumors occur and has been well described in terms of historical distributions, and more common amongst the Far East, like Japan, Korea, and China, for the germ cell tumors. And the pineal parenchymal tumors are probably more the common in Western Hemisphere. Now, WHO 2021 classified a tumor with CNS, and the categories of pineal tumor, which include pineal cytoma, pineal parenchymal tumor of the intermediate differentiations, and the pineal blastoma, papillary tumor of the pineal lesion, and the new one is desmoplastic myxoid tumor of the pineal lesion, which is essentially the adult disease. I don't touch this particular tumor because I have no experience of that. Now, papillary tumor of pineal lesion, I thought this is not the pineal origin tumor, but WHO include this tumor into that so-called pineal tumor right now. Now, this is tumor, for instance, this boy, teenage, who started with headaches, and I don't see any abnormalities, but retrospectively speaking, here is abnormalities right there. And probably that is causing intermittent CSF obstruction, yet there's no hydrocephalus. And this tumor, papillary tumor of the pineal lesion, took origin at the subcommissural organ just anteriorly to the posterior commissure. And about 3 years later, he became more symptomatic, and that showed the tumor. And it's turned out to be a papillary tumor of the pineal region. Now, a pineoblastoma, I don't get into the molecular part, but in essence, now this is well published in the literature and so-called molecular classification of all those embryonal tumors, with pineoblastoma belong to one of them. And essentially, baby tumor of pineoblastoma is bad disease, and still we are struggling how to treat this particular group of the patient. I think Dr. Morita mentioned about histological confirmation, but sometimes we can get some idea what's going on in the tumor itself among the germ cell tumors. This is a 19-year-old boy with double visions and headaches and vomiting, and endoscopic biopsy showed mixed germ cell tumor. But when you look at the change of this particular so-called tumor markers, serum AFP, CSF AFP, serum ACG, and CSF beta ACG, all elevated within 1 or 2 weeks. It's progressively worsened. And the patient had a shunt placement done at the outlying hospital. And we concluded based on this tumor markers, oh, this must be the germ cell tumor, and particularly mixed type, because both AFP and ACGs were elevated. And so the patient was used the chemotherapy, and tumor essentially melted away. And then AFP and beta ACG also decreased very significantly to nearly 0. And then there's still persistent small lesion, and therefore second look surgery was done. It's turned out to be a benign epithelial component. There's no active cancer cells. Now, over time, the about 100 plus cases we treated, this is kind of old slide on mine, but about 42% of pineal region tumors were germ cell tumors, 18% pineoblastoma, and 20 were astrocytomas. Among the germ cell tumors, most common one is the germinoma, and I'm sorry, I have no. And mixed malignant tumor occurred quite significant number, but I think the important thing is the most of known teratomatous tumor among the germ cell tumors responded to oncological treatment, but teratoma is indeed the surgeon's disease. Now, diagnosis is quite straightforward. History and the physical, sex, and age are very important to predict what kind of tumor might be. Imaging has progressed, and we can get some idea. But if accessible to serum and AFP, serum and CSF, we have to always order tumor markers. And if CSF sample is obtained, try to send all those samples to the cytology. But ultimately, those patients may require the biopsy and subsequent decision of the treatment. Now, the patient has a DI. You have to be careful if anything missing in the hypothalamic location. Age-wise, ATLT and pineoblastoma occur at a very young age, young infant. On the other hand, common germ cell tumors can occur 8 years or older. So this can be distinguished some the difference clinically, what we expect to see for pathological point of view. And sex is very important. When we look at our recent data, I had 42 pineal germ cell tumors and 16 bifocal tumors. Essentially, everything happened among the male population yet. So solitary suprasellar tumor, germ cell tumors, essentially it's a girl's disease. So I think sex is very important. Now, pineal calcification, if we see the calcium in the pineal location, younger than 6, you have to suspect something wrong. Because after 6.5 years, the calcification can take place gradually, and about the teenage boys, about 30–40% of the human being have a calcified pineal gland. The calcification, as I mentioned, very top one is pineoblastoma, just I showed you. This is more diffuse, the particle like the calcification, kind of dispersed calcification in the pineal location. Yet geminoma calcification is more displaced centrally or peripherally. But that's not necessarily the rule. For instance, this one was a very oldest patient with pineoblastoma, had a localized calcium deposit. So that's not necessarily the decisive factor, but the curiously, this patient is indeed a girl. So it's kind of unlikely to experience this type of mass among the girls for subpineal geminomas. And pineal geminoma, this is well described in the radiology literature, and you can see some sort of involvement of thalamic and subependymal involvement, some diffuse edema in the thalamus, and the subependymal extension is indicated by the creepy appearance along the ependymal layer. Now, hemorrhagic mass, and you have to strongly suspect choriocarcinoma. And sometimes pineoblastoma can present with hemorrhage into the pineal tumor, but more common one is obviously choriocarcinoma, like this patient. The teratoma is obviously, this is our favorite topic when we talk about pineal lesion tumors. You can see a very inhomogeneous, hypodense mass with a few area of calcification or hyperdensity and brightly enhancing after contrast enhancement. This particular patient presented with some rupture. You can see a white dot here. This is a ruptured teratoma's dermoid component. So it's shedding into subdural space or subarachnoid space. Now we talk about tumor markers, AFP, beta ACG, and a placental alkaline phosphatase and soluble KIT. A commonly used one is AFP and beta ACG because the PRAP and soluble KIT need some special arrangement. I think most important thing is the AFP is maybe elevated younger than 2 because of immature liver and immature embryonal structures, but yolk sac component need to be concerned, and beta ACG is essentially should be negative in the CSF. But if his CSF is weakly positive, like 6 or 7, I think we conclude pretty much those patients has the germ cell tumors and treat it accordingly. This is not the choriocarcinoma when CSF beta ACG is lowly expressed. Those are the presence of sensitive trophoblast. So, but also this half-life is very important. Except for beta ACG, Others, essentially half-life is about 5 to 6 days, but beta HCG is less than 1 day. So when you start to treat those patients and check that the value, you can see the response to the treatment, to the chemotherapy. The tumor markers should be obtained both serum and CSF. AFP tended to be higher among the serum than the CSF, but on the contrary, the beta HCG are elevated more often and more common in the CSF than the serum. So we had to check both serum and the CSF for the tumor markers. The hydrocephalus management is a wonderful neuroendoscopy is available, so we use ETB and biopsy, but the EVD is, I think, a very important part of the treatment at the time of tumor resection, and hopefully EVD can be removed postoperatively. Often we receive the patient who are shunted at the outside hospital, and if you approach through interhemispheric transcendental approach, sometimes brain become very tight. So I wish they send the patient earlier before putting a shunt in. But obviously, the best management of the hydrocephalus is resecting the tumor, which is a cause of hydrocephalus among this particular disease. Now, when we do this endoscopic inspection, I think endoscope gives us a lot of information. For instance, this patient had a pineal lesion mass, and this is a flexible endoscope. This is a flow of the third ventricle on this endoscope, and posteriorly, aqueduct is nearly closed off because of this turned out to be a germinoma. And then looking at more forward to see the floor, anterior floor of the third ventricle, that is the quite thinned out floor, and you can see mammillary body, and anteriorly you can see some not normal looking appearance that turned out to be the infiltrate of the germinoma, and you cannot see a good vascular stain of a tuberous snarium, and this patient had ETB done. But more curiously, we don't see any mass or so-called the focal lesion in the hypothalamic location. So I think endoscope can give us a better idea of what's going on in the brain. Sometimes this patient had EVD and then transferred, and we use a steroid. He feels better, and after use of steroid, this CAT scan, this before and this after the EVD for 3 days and use of steroid, please note that the quite the reduced mass, this partly calcified mass, is turned out to be a germinoma, and because of presence of T lymphocytes, which is about 80% of lymphocytes of the germinoma, respond to the use of steroid therapy. Now, hydrocephalus, and it is a very common topic among pediatric surgeons. Use of neuroendoscopy and use of ETB and biopsy. Sometimes people can do a tumor resection if the mass is very small. And rigid versus flexible scope, that is makes some difference in terms of clinical management, because trajectory is quite different to the throat of the third ventricle versus the posterior part of the third ventricle. If a flexible scope is available, you can take a look at, like I showed you by the slide. But Schulz and Tomari from Germany recommended to use the different, instead of two different trajectory between those two. But this approach may be a problem because you may not conduct either of the purpose, that is ETB and tumor biopsy. So this is one of those two barhole approaches, ETB for the coronal. Usually I make a barhole in the coronal suture, and then another barhole is done for the tumor biopsy, aiming more toward the back walls. Now, this is a common procedure. For the interest of time, I can't get too much, maybe run slide together. So this video of the left side is doing the ETB, and then flexible scope is turned backward, and then doing the biopsy. But you have to be careful. Sometimes these tumors may be quite vascular, and this need to be very carefully conducted. I had one patient who had hemorrhage and needed emergency craniotomy. Now, treatment principle is essentially germ cell tumors is teratoma is a resection, but geminoma is essentially oncological disease. The rest of them, like second look surgery, which involves the neurosurgeons, pineal parenchymal tumors, ATLT, those are all involve the surgeons. And astrocytomas, I think usually we observe to see how it goes by management of the hydrocephalus. And if tumor progresses, we may use a chemotherapy, but not the radiation therapy. But usually, most of the astrocytoma in the midbrain location are benign JPA, and therefore, accordingly, I usually recommend the surgical resection. Now, this is one. So this is a kid who had a 12-year-old boy with headaches and perinode, typical feature of germ cell tumor, and that would be a geminoma because CSF is weakly positive. And then this patient had oncological treatment. After the 3 months use, tumor is gone, and then we treated with chemotherapy. Now, this is another patient, 17-year-old boy with non-geminomatous germ cell tumors. AP is elevated, and so treated with chemotherapy, and the residual disease, partly cystic disease, was resected at second surgery, which turned to be mature teratoma. Now, a growing teratoma, which is a unique concept. This patient had chemotherapy was used for this what appeared to be multicystic lesion because serum level is high. And after use of chemo, serum level of AP dropped, yet the tumor continued to grow. It started to be a mature cystic teratoma, and that was treated with non-geminomatous germ cell tumor protocol. And actually, localized CNS and geminoma and germ cell tumors were treated with more or less a local radiation treatment, which means whole ventricle treatment for the radiation, but upfront chemotherapy first. And then this the COG protocol provided a quite impressive improvement of the survival rate. Nearly 90% of the patient has shown a quite impressive response. Now, pineal parenchymal tumor usually recommend surgical resection. Astrocytoma, as I mentioned, surgical resection. It was the last line. Now, I don't get too much historical perspectives. Cushing and Dundies were quite afraid to do surgery. This approach has been defined by several predecessors. Dr. Stein proved the infratentorial supracerebral approach, and the interhemispheric approach was used by Apuzzo and McComb. And the the approach, occipital transcendental approach, which is today's subject, was the Poppen first described in 1966, and Jameson improved and refined this technique. Now, when you talk about how to approach, this is multiple approaches were used: infratentorial, supracerebellar, occipital transcendental, and transporosal approaches. And each has a advantage and disadvantages, but I think essentially what is how to expose and surgeon's experience and comfort, if you can use assistant or not, and what is the position to take for set up the surgery, and what is the location of the vein, and more importantly, what is blind spot. Those things we have to consider. I not use the infratentorial supracerebellar approach. This is the last patient I used for this particular approach almost 30 years ago because of very uncomfortable to look at. And also the blind spot is essentially this cerebral mesencephalon triangle right over there. Sorry about that. So this is among this description. He had this monograph. It's very difficult to, even though you have an armrest, it's a very tiring, and some teratoma takes much longer time, and it's quite hard to conduct the surgical approach, and also focal distance is quite long. So I use the posterior interhemispheric transcendental approach, which give us a quite large exposure, and I don't have that much time. For instance, this patient, this quite large the teratoma, obviously, and this is approached occipital transcendental approach. Now, can you access to the opposite side? Yes, you can. And this one, more concern is a more medially one. But this type of tumor, you can first debulk it and then bring that lateral wall to the surgical field, and this section can be done like this. Now, one of the concerns of this approach is compressing the visual cortex. And Matsuo wrote with Dr. Lawton this anatomy here. This is a calcareous fissure right over there. And the surrounding area, which is occipital lobe, obviously. This fantastic article written in European Journal of Radiology. All those B1, which is a primary visual center, is on the bank of calcareous fissure, but along and below, which is icneus and lingua, those are secondary visual centers. So most of the time, even though compression is done, most of the patient's visual field come back, even though hemianomic immediate postoperative time. Now, occipital transcendental approach was pioneered by the Poppen and then defined by Jameson. The difference between those two is Poppen used so-called lateral suboccipital. Suboccipital means lifting up the occipital lobe, and Jameson is an interhemispheric type. So this gives us some idea how it's approached. Now, the Motolysis also use this similar approach, but you can expose both the tentorial surface and occipital lobe by lifting up the occipital lobe, but also getting to the interhemispheric approach. The approach is very important, but I think far most important thing is ventricular relaxation attained by EVD, and if shunt is present and slit-like ventricle is the case, I have no problem to externalize the shunt during the time of the operation. The gravity-assisted one is well described. Osman started this 3/4 prone position, which I used only one time and took a long time to set up the position. So I always use a prone position with head turned sideways and sneak into the interhemispheric fissure and drain the CSF from the system. Occasionally we have to use the monitor, but we try to use monitor because once CSF is drained, so everything becomes so relaxed, and the monitor will aggravate too much of the brain relaxations. Gordon McCorm used the lateral position, so-called recumbent position, and but this position sometimes is very difficult to control that reduction of the traction of the occipital lobe, and you have to remember there's a whole bunch of bridging veins, and that can be a problem. It may too much reduction of the occipital lobe happens. Those veins start to bleed. So I use a prone position, head turned about 20 degrees, and I use that in the neural navigation system. Bar hole is done at the lambda, about 3 centimeters over the superficial sinus from the lambda anteriorly, and this above the ilium. And this craniotomy is done, crossing the midline, and then approached. The breaching veins is always present, about 2 to 3 centimeters above the lambda, but below that, which means posterior to that, there's no bridging veins, so you can easily enter into the interhemispheric fissure. Now, sometimes we may not have a good space. This large immature teratoma has a quite large space between the venom garden and the tectal plate. And other patients have no space, and this particular patient had to struggle. So ultimately went through a transsplenial section and went from above the roof of the subventricle and tumor resected. Now, even though this pre-tectal plate that is aqueduct, beginning of the aqueduct of the cervix, that can be removed and controls that mass. Large tumor, I already mentioned, opposite side, how can you control? Again, this type of tumor, you can decrease the mass by decreasing by the internal debulking, and then bring the tumor, lateral wall into your surgical field, and then you can deliver this tumor. So I think even though it's extending to the opposite side, once internal debulking is done, you can bring the size of the mass smaller, which allows us to inspect the lateral wall. Now, parapineal tumors, I'm not sure you have time to do so. The midbrain, tectal plate, cerebral peduncle, and posterior commission. Just to show you, this is a very delicate part of the brain, how much you can do that. And essentially intrinsic versus exophatic or invasive. Unfortunately, we don't see not much malignant gliomas like the DIPG type condition in the midbrain. So, but there's a variety of tumor could happen. This is a tumor which happened in the suburban location, which turned out to be a medulloblastoma. And this is a tumor which turned out to be a benign astrocytoma. And this can be approached very similar fashion. And some tumor and the medial, the occipital lobe can extend to this pineal location. Now, how about this type of tumor, which occur, I suspect, the cerebral peduncle origin. but also tegmentum is largely involved. And this can be approached by section the tentorium, and you can do this is section renal gallons here, and now they separate away from that backward. So taking this part of the tumor out and using this side. This patient did very well without a neurological deficit. And some tumor is very cute one like this, Tumor origin. And usually I don't do any surgical resection for the tectal plate tumor, but this patient had enhancing partly cystic lesion. Therefore, this tumor is resected through the same approach and resected like this. So one side tectal plate appears to be intact, and this patient did not have any auditory or the ocular dysfunctions. This kind of large mass, we do not know what exactly tumor comes from. Only thing we can tell is based on the postoperative imaging, and I conclude this is likely the thalamic JPA extending into the posterior side of the ventricle. Now, midbrain tumors, very similarly as approached. Now, this one, last one is a tumor of supermedullary biram. Supermedullary biram is right over here in front of the lingua, and also inferiorly to the quadrigeminal cistern expand. Therefore, it's expand to pineal cistern to the fourth ventricle. And this type of tumor is ideal situation to remove through the posterior interhemispheric approach. And this patient tumor is extended all the way to the cisterna magna. So this tumor is quite impressive, more largely necrotic, and fortunately, this is a so necrotic tumors keep oozing out once open up the tentorium. This is tentorium right over there, and this continue to oozing, and then you can, after the debulking the fourth ventricular mass, that you can get into some more inferiorly to the, this is a pontomedullary junction, and essentially G tumor was removed in a good resection like this. But unfortunately, this is ATRT, and patient needed extensive chemotherapy. So in conclusion, a lot of different type of tumors can happen in this particular location. But 60% are probably the pineal gland origin, but the rest of them are parapineal. Histological verification by means of tumor markers and biopsy lead to the appropriate selection of the management. And posterior interhemispheric transdental approaches useful for pineal region tumors. But in order to do the successful interhemispheric approach, brain relaxation is essential. And most of exophilic or extrinsic tumors are amenable to the recession. I conclude this one here, but also we should remember what's going on in Ukraine. I just hope this misery ends and restores a peace in Ukraine and children. Thank you very much for your attention.
Thank you very much, Professor Tomita. I have one question. You don't try to take biopsy in germ cell tumor in general. So in that case, after chemo or radiation therapy, the pathological diagnosis sometimes becomes very difficult, even if you perform the secondary surgery, right?
You know what? The biopsy can be done, but use the endoscope, not open biopsy.
Yeah.
If you like to take a large sample, I'm not sure if justifiable. First of all, if you have the positive tumor markers, and then putting a risk for the surgical risks like a hemorrhage, and the number one. And number two, if the tumor marker is negative and biopsy is not conclusive, obviously had to go to the OR. But simple biopsy purpose and open biopsy is justifiable or not, because if you like to do remove, you have to go remove it instead of the biopsy. But if we do main purpose of biopsy, I think we have other way to perform. I think the biopsy by endoscope, and sometimes we use a stereotactic biopsy, which we don't use, much less common. But I don't know if taken large sample of the tissue to see if any choriocarcinoma component or yolk sac component. I think those things can be determined by the tumor markers as far as I'm concerned, and also response to the chemotherapy.
So my understanding, and most Japanese pediatric neurosurgeon think the tumor marker is very reliable, but not perfect. So combined with the tumor marker and the biopsy specimen, we can reach more precise diagnosis. This is my understanding for why we take the endoscopic biopsy for pineal lesion tumor, especially the germ cell tumors. And yes, and next question is, let me see. Oh, okay, yeah, that time.
So, no, but one more thing. If you do the biopsy, okay, endoscope biopsy, or open up and take a little piece, or here, germinoma, let's stop. Usually you do that. But that does not represent entire tumor profile, because maybe it's 5 millimeter away or centimeter away, there's a different component. And from surgical point of view, most important component is a teratoma. So if choriocarcinoma or embryonal cell carcinoma, those things is a more oncological thing. And we cannot completely eradicate, because we can remove the entire thing out. But that is not the purpose of the surgery. I think the treatment should be directed to what could be, that is non-germinomatous, non-teratomatous germ cell.
Yes. Okay. And regarding teratoma, you mentioned about the growing teratoma syndrome.
Yes.
And my understanding about growing teratoma syndrome, the growing of not the tumor itself, usually the growing of the cystic compartment of the teratoma. Is it right?
Right.
Yeah.
Yeah, that's correct. Growing, I think the initial definition is after the use of chemography, the tumor markers return to normal.
Yeah.
Yet cystic component expand. I think very active glandular cells or some sort produce that tumor cells.
I think whenever the immature teratoma has a cystic component, I already prepare for the growing teratoma syndrome. Yeah. Thank you.
Thank you very much. We can take other questions. Any questions from my co-host Libun Singh?
Thanks, Raja. Thanks, Prof, for extensive talk. I just want to have two questions, Professor. Regarding ETV, do you need a MRI before an ETV? Before you perform ETV, do you really need an MRI to be performed? My second question, Professor, what is the youngest age that can go for radiation therapy? Thank you, Professor.
Okay. The ETV, you already routinely obtain the MRI, and when we do the MRI, you routinely include the spine as well for the reason of staging. And once you do, ETV gives us a much better idea what's going on in the brain than the CT scans alone. If you are not able to access easily to the MRI, because you can use the CT scans, but the CT scan with a reconstruction and with contrast can give a good idea for the ETV purpose. If we are planning to the biopsy, endoscopic biopsy, in that case, I think it's much better to have some MRI, because you may see surprise without knowing what's going on. As far as radiation therapy goes, we try to avoid some radiation younger than 3. And because a lot of neurocognitive and endocrine problems after the radiation when they are exposed to some radiation treatment. But some tumor like ATLT, I think oncology people use stem cell transplant and so on, very aggressive treatment. But I think without radiation therapy, particularly those ATLT and pineoblastoma, it cannot be cured. So this is a very difficult problem in pediatric oncology as to how we can avoid the radiation therapy if possible. But I think oncologists are making effort.
Thank you, Professor.
Thank you very much.
Thank you.
If I may ask Professor Tomita one question, that most of the patients you have operated is in the prone position. So from what age do you recommend using pins in pediatric population?
So if the patient, let's say you have to make a judgment, obviously, and particularly first maybe year, I did not show that device we call Infinity. That is pins which allows only 2 pounds torque pressure with horseshoe head holder is combined. So that gives a good securing. But most of the time, first year, I have no problem to use the horseshoe head holder. And you have to remember those patients with the pineal region tumor present with hydrocephalus. So we don't have turn the head sideways to get benefit of gravity control. And second, this is not posterior fossa craniotomy. This is supratentorial craniotomy. Therefore, we do not have to flex the neck. You can keep the head in the neutral position. So it's much easier to secure the prone position, even though very young person without pins. But I think usually the first 3, 4, 5 years, I always use a 40-pound torque pressure for the pins. Never use a 50 or 60 for the grown-ups.
We have Takashi Kon, who has joined us from Tokyo. Any questions from you?
Thank you, Dr. Tomita, for very informative lectures. So I'm Dr. Takashi Kon from Tokyo, Japan, Showa University. Formerly, former Professor Dr. Tanaka, Ryuichi Tanaka, performed the pineal region tumor via occipital transcendental approach. And these days, we perform endoscopic biopsy and verified histology, and then treated the patient. But sometimes we're still confused whether there is a pure germinoma or a mixed germinoma. So carefully following the patients. And to diagnose the patient and following the tumor marker is still confusing. So we have very few experience of diagnosing and following via tumor marker. So I learned a lot from your lecture, and I keep learning and challenging approach for surgery. Thank you for the lecture, Dr. Tomita.
Thank you so much. But no such a thing as mixed germinoma, right?
Yeah, mixed
Germinoma
mixed.
is the mixed germ cell tumor.
Yeah.
Okay.
Right, so I think we have learned a lot, and our speaker and the chair for second session is ready. We can hear the final remarks from closing remarks from Professor Morota.
And I appreciate Professor Tomita's lecture very much. We understand the whole view of surgical approach and the history of the surgery of the pineal region tumor. Thank you very much.
Thank you very much.
Thank you very much, Professor Tomita and Professor Nobuta Morata, for this wonderful lecture, and we are indeed so grateful to you. We'll move on to the second session, and I would like to invite Professor Ali Reza Manzoori for a short introduction and invite
Thank you.
Yes.
Hello, good morning, good afternoon, good evening. I'm delighted to introduce Dr. Musabeliu, who will give us a talk on melanoma brain metastases. It's a very rapidly evolving field, so I'm very excited to hear about all the latest developments. Thank you.
Hey, good morning to Western Hemisphere, and good evening to Eastern Hemisphere. I'm so happy to be here with you today, guys. It's a challenging moment to follow the lecture of Professor Tomita, especially when he got to talk about very challenging surgical decisions we have to make in our everyday life, but at the same time for very rare diseases, which I'm passionate about. Now, I'll try my best to stand at the quality of his talk, but I feel short of it. Thank you, Dr. Mansouri, for introducing me. So is it okay, the quality of the screen you see on your end?
Yes.
That's wonderful, thank you. So it's a topic that I'm very passionate about. In recent years, I've been following different machine learning algorithms and artificial intelligence combinations for me to collect data on the topic of metastasis in general. And of those topics, I find melanoma to stand alone. On the topic, I must inform you that I have no disclosures, and this is just work that I've been conducting out of my interest in research. As a former trainee and fellow, this is the paradigm I used to think myself being part of earlier in my training back home in Albania. And I realized that some of the steps are beyond my abilities to control, but I tried my best to stand on the loop. And I realized that in most of the steps, for different reasons, either institutional or local or due to socioeconomical or political challenges, I wasn't able to complete the loop during my training. So I took it upon me, and it was a big step during that to emigrate and to try to find ways or opportunities for me to attend a meaningful, fulfilled training that would combine not only knowledge in neurosurgery, but combine that work with research and having the opportunity to share the work with colleagues. So the data that I've collected comes from different sources, mainly that's from US, but I will caution all of us to be careful when we use the data, not just because it's only one source or mainly few sources, but of the evolving speed of the current research in the field of metastasis in general, and that of brain metastasis more specifically. This is a layout of what I will trying to share with you today. I want to start my talk and taking prelude from what I earlier mentioned. Although this is irrelevant to the specific talk in brain metastasis, I always use in recent talks that I've been giving these two articles. Related articles that come from 2011 in regard with the way patient outcome to treatments during a COVID-19 period, all to tell us that there are ethnical and geographical differences among us, although we share the bulk with each other from east to west in the hemisphere. The problem is that we have differences, and those differences truly make a difference in the way we are diagnosed, in the way we respond to treatment modalities, the way we follow or we survive following the treatment modalities. Now, brain metastases remain the #1 disease in neurosurgery. It is truly a challenge. We see, all of us have seen it in everyday practice, and what we hope is that someday soon we'll be able at least to minimize the burden of the disease, other than having hope for it to be cured. There is luck in statistical and epidemiological studies throughout the world, coming mostly from Western and well-developed countries. These are 2 points I want to make. If we were to discuss about metastasis, the true definitions has to change regarding not only to metastasis, but as well to brain metastasis. I took point of National Cancer Institute from their National Library of Health for a very simple reason. It is a source of reference for many of us. For most of us, it's a trustful source, but it has to be changed for many reasons that I'll try to explain throughout my talk. Now, when it comes to brain metastasis, we are very aware that in most regions, and I point out in most regions, not necessarily geographically spread to the same frequency, we find these in the same order. About 80% of all cancers that metastasize to brain come either from lung, either from breast, or melanoma if that's a man, or colorectal. Now, we would see that the incidences varies because there are not truly or throughout spread epidemiological studies that would give us what is the bulk of this disease in each country. And that's quite impossible this time to have the results. So that's why I put the wide range from 9 to 17, the incidence of this disease, by the time of diagnosis for our patients to have been diagnosed with as well with the brain metastasis. Now, if we were to put the numbers, and we see the differences highlighted here are a country like Sweden or Netherlands, we see that in men is the second source to give metastasis to brain. It stands out, it's melanoma. It is as well very common in women, but not to that range. If it comes to find out in different states within US, and this is highlighted here, is Detroit, who had a very wonderful database to collect data from other than SER in US, we see that the second common primary is melanoma. It is very common in men. It has a high propensity in African Americans, which is very often one of the most common primaries. And beyond 5th decade of life, it becomes the primary source to spread to the brain. This is another study. I just had the opportunity when I was conducting and collecting data that this 2022 work came in from Canada, the first and the most meaningful, lists the incidence proportion of melanoma to be the 4th. We see that the difference is about 10 times fold with the lung, but melanoma in its own right stands out there as a tumor that really requires careful exploration from the origin all the way to the brain. So the SER data of 2019 shows that at the time of diagnosis of a primary disease, we have melanoma patients diagnosed with a brain metastasis in about 1% of them. And this is a significant number. When you see that 1% maybe might not be significant, but truly is significant. And by the lifetime, I mean that it is remaining the second most common of all of cancers that we know as the primaries. If it comes to pediatrics, the data is limited. It's a coincidence that I had Dr. Tomita earlier giving a talk, but throughout the world in pediatric data is limited, not only because it's a rare disease in pediatrics, but as well because we don't really understand the mechanisms that govern those tumors in pediatrics and those tumors in adults. I find these standalone pathologies too different. And when we give talks, I try to keep those separate. So my talk here is focused on mainly in adults. When it comes to skin cancer, as we alluded earlier, we saw that melanoma, which is one of the most common skin cancers, is a very common primary to brain metastasis. And when we speak in general for skin cancer, it's #1 cancer in US, and most likely that is the case throughout the world. And of those, melanoma has a difference, which is very huge. Before being diagnosed, up to 22% of cases in melanoma patients later diagnosed in life have already spread to brain. And that's a huge number, which is the oppositional difference with basal cell carcinoma and squamous cell carcinoma, which appear, and luckily so, speak clinical way ahead of time of their invasion. In 2018, melanoma in US alone, ranged up to about 90,000 people diagnosed. And of those, about 9,000 died, and 2/3 of those, as I mentioned earlier, were beyond their 5th decade in life. Now, I put together these imaging just to illustrate, but my point in this slide is what I've been curious to study about the origin of melanoma. It comes from ectoderm, which makes it a tumor that stands alone. All of its components come from ectoderm. It is extraperitoneal and extracavitary, which makes a huge difference in regard of other common diseases that spread to brain. And I need to mention here lung or all GI tract tumors. And it does not need to go through heart, to go through lung or liver, because in most of the cases, and as we would see later, it bypasses these three vital organs that at some point in life for other cancers has been considered as filters or stop stations in cancers that originate from other organs, but that's not the case with metastasis from melanoma. If it is about skin cancer epidemiology, and that's our data from US of 2019, we see that the incidence is increasing onwards from 1990s. The mortality rates remain stable, and that's the treatment paradox that I commonly see despite the advances in the treatment. When it comes to melanoma, the third most common of skin cancers, it has different types, but I need to bring back the thought of being originally from the same layer of embryologic development, which is ectoderm, and this is very important. Now, we have staged melanoma in gross, and it is a pathological appearance. The reason that I showed this image here, it has relevance for most of dermatology and pathologists that are not necessarily neurosurgeons or neuropathologists, but I want us to use this slide and bear in mind for further reference as I go through this talk. Stage 2 melanoma. When it comes to its potential to metastasize to brain, almost 40% of stage 4 melanoma have already metastasized to brain. And of those, about 70% present symptomatically. And if we are to see what's the median survival of patients diagnosed with metastasis from melanoma, it's 4 months. It's very short. And if I am to bring an overall survival data collected from throughout different sources, it's up to 9 months. And most of the patients, which is this number here that I wanted to highlight, have an identified source. Although we do study their pathology from what we collect samples from their brain tissue metastasis, we find out almost impossible in 20% of cases to identify where is the primary coming from. It is not a tumor that spreads in many locations within the brain, but it truly has a preference to locate within the frontal or temporal lobes, not necessarily are present in other locations within the brain, but it does preference frontal and temporal lobes. When it comes to stages, the second through fourth account for up to 25% of all cases that we have diagnosed, and that's why I wanted to point out second stage of this disease. And in up to 40–45% of cases, BRAF is mutant versus the wild type. When it comes to what we see in daily practice, the metastasis of origin from melanoma, it's about 1/3 that we see one single metastasis. And the other third is about up to 2 to 4, and that's where the challenges lies. How do we treat those patients and how versus one single metastasis? When it comes to what we see in clinic, about 2/3 speak neurological. They have clinical symptoms. And of those, 40% have neurological deficits. I want to stop a moment here and lay out what I've been finding out throughout my researches. Just like a different beast and in neurosurgery, which is glioma, metastasis on its own and that of melanoma does not make a difference. They do not invade. What I mean by that is within the brain tissue, they have a favorable spot, and their favorable spot is the margin in between gray and white matter. And it is there where we would find most of our metastases in gross specimens. The problem is that they spread out throughout and between. But when we find the tumor, to speak neurologically, they have already grown in such a size and volume that although we see huge changes in their imaging, literally, if we were to open up, it's about pressure within vicinity structures and not invasion that produces the clinical symptoms. Now, if it is about their location, about 95% are supratentorial, and what we find out is that in about 40% or so, those lesions are hemorrhagic. When it comes to mechanisms of tumor spread, and I want to take a point out of it, it's the paradox of the distance. We have been informed throughout research and published work that it's via either blood that or lymph node spread, or through migration, which is a physical, literally the physical movement of the cells throughout different layers, not truly invasion. And what it comes is, how do they cross the blood-brain barrier? Now, the paradox of the distance, and I want to reiterate this is very important. Of the head and neck cancers, very rarely we find them to metastasize to the brain. In contrast, almost all melanomas located in vicinity to head and neck or upper trunk quite early in their disease process would metastasize to brain. Now, this is what we have been taught, and this is quite a meaningful way of believing that is a way that the tumor spread. And I would say, yes, it is. I've seen papers that show us data that it indeed, the tumor moves to regional or distant lymph nodes. Tumor cells indeed do cross different layers, and they reach out the blood, and via bloodstream can move to other organs, including brain. When it comes to how frequent these tumors are, the problem is not the frequency, the problem is location. Through different sources, whenever I can collect, I find out that the region of upper torso and then head and neck has higher chances. And this is why I wanted to reiterate this point, is because this is how in clinic we can predict, if we get an information from colleagues in dermatology or in pathology that they have identified at least a stage 2 in upper torso or head and neck, I would warn them and be cautious not to let it sleep, but investigate further. In 1986, researcher Elizabeth Hay from Harvard, as I was studying the development of embryos, found out that at the time of conflict in between epithelial and mesenchymal cells, the interplaying between receptors of each tissue layer laid out the future development of the embryo. And the two signal each other that this is my territory and this is your territory, and here we bond together and we move and we produce a species, either that being human or chicken for that matter, or zebra fish, if we were to say. This is later been used as one of the cancer and metastasis hallmarks, but I wanted to point out the year 1986. Elizabeth Hay moved forward to mention this as a theory, not long from her first work, and all to find out that this is a mechanism that not only melanoma, but many other cancers that need to cross different layers have to gain as a function in their process of disease to have access to blood and then to spread throughout different organs using blood. In 2000, just shy by a month or two, but 14 years later, colleagues of Elizabeth Hay from Harvard published the Hallmarks of Cancer, and then they revised those. The same colleagues, Professor Bob Weinberg and Dr. Hanahan, to see, just to tell us that among those acquired differences in cancer from differences from the normal cell is that they have this potential to acquire a transition from epithelial to mesenchyme. But it took them about 14 years. In between those many years, a ton of development has occurred in science, but only later we had to understand that not necessarily every single process requires the transition from epithelium to mesenchyme. If it comes to diagnosis, I would caution you to read throughout the slides, but this is what I do in my practice when I am aware that I have come across a brain metastasis. I try to figure out if I have an unknown origin or it's a primary that we know, and that it really makes a difference in the treatment plan rather than the diagnosis. And I've seen both in life. I've seen a primary known and a primary unknown. I want to bring back the statistic number that about 22%, which is a quarter of all cases that we generally see, have an unknown primary. When it comes to a differential with glioma, I'm not any better than most of colleagues. I do trust the radiologist, but in recent years, I've seen an advance in radiomics that can be combined with softwares that can be put in current, and that I mean in current use CT or MRIs. Necessary. This is not related with the income of any country, and I bring history from my own experiences from a low-income country. We can put together a few members with a team of mathematicians, physicists, and our radiologists, just to set up a different model for us to help differentiate a single lesion from a glioma. When it comes to stereotactic biopsy, I try to stay away unless it is in a very challenging, surgically challenging region for a very simple reason. More and more data collects that through stereotactic biopsy, especially if the lesion is cystic or hemorrhagic, it has the potential for us to inseminate tumor cells within the tract. It is true that the gold standard is pathology. For the unknown, we find out that we have a melanoma, and we still cannot find where it is the origin, but we know that it is coming from melanoma. And when it comes to liquid biopsies, I would use cautious in advising use in massive, especially in low and middle income countries when financial resources are limited, because their sensitivity and specificity is low to the day. Yes, for clinics that have the opportunity to use this in their everyday evaluation of a treatment outcome, I would make use of those to see the treatment progression, but not necessarily to diagnose and to find out where the primary is. Now, I want to bring back the slide for this very simple point I made earlier, the stage 2. I would caution our colleagues, and I speak very commonly and very frequently with my colleagues in the Department of Dermatology, when the case is that if they see a stage 2 lesion that's coming from upper trunk and head and neck, they should call a consultant, us, and we would always, and that's my experience, recommend at the time of diagnosis of a stage 2 from one of these areas, we conduct an MRI. Do we find any differences? Honestly, yes. Does it make help? I would say yes. Can we actually predict metastasis? Can we predict, once we find out that we have a disease in one of these stages from 2, 3, or 4, can we predict that we are going to see in the very near future metastasis coming out of this lesion? For low and middle income countries, it might be challenging. It requires genomic studies. But I want to point out what we know is that if a primary has one of the genes listed here, which I must point out that not found necessarily in all tissue samples that we have collected or researchers have collected and published, there is a high chance, I'm not saying 100%, it's impossible to say that, it's a very high chance that the tumor is going to metastasize, and the one of the final organs, if not the only organ, is going to be brain. The problem is that with the distance from the primary, the more a combination of these genes in the primary and the closer to the brain, which is the head and neck and upper trunk, the higher chances has for that lesion for stage 2 and onward to metastasize to the brain, and especially if the lesion has alterated. If we move on, and I would show you just to point out the old way of using the TNM classification and the more advanced way, which is doing genomic studies. To a certain degree, we can say yes, that we would be able to predict if a tumor is going to metastasize, irrelevant of the stage, if it is stage 2 and onward. Yes, we can predict if a tumor has a higher chance to give a leptomeningeal disease, and that is the case if the tumor shows an MRI being hemorrhagic or being cystic. When it comes to the composition of the primary and then having the composition of the metastasis, these are simple tissue samples collected from the primary of the same tumor, and then the metastasis. You'd see hematoxylin, eosine stains, which are normal and work what we do. We don't have advanced technologies in a low-income country to conduct genomic studies. The reason I put the gross specimen is it is here where most of metastasis lay. It's a cross border in between the gray and the white matter. But the point of the slide is that although the cell of the primary, which is this one, has commonalities with the cell in the metastasis, huge differences exist in between the two. Now, and I want to show what are the differences in between the two. In melanoma, the primary, and that of the brain metastasis, highlighted in blue are genes that are common. But at the same time, the genes that we commonly find in the primary, which are found in the metastasis, those that we find in the metastasis later in the disease process, if we were to collect a second sample from the same location, we would find that they have mutated. They have either produced loss of function or a gain of function in their role throughout their cell cycle in the processes of making the cell immortal. When we talk about melanoma, I always want to point out, and this comes to the talk that to the part of the talk that I'm going to bring later. Melanoma and all cancers are composed of different cell types. The most challenging for us is the study of those that are slow growing, radio and chemo-resistant stem cells, which do not compose the bulk of the primary, but it is the one that has the potential to keep the primary viable. We are informed through research and work done by colleagues that the tumor cells make it to blood. I would argue that's not always the case. Even when we find a metastasis, these are studies conducted in zebrafish that show us the presence of the tumor in the blood, tumor cells, and tumor in the primary and tumor spreading and crossing the what it is the neural tissue of zebrafish. The problem is that if I go back and then I would make it even more heavier. The slides of this talk is that very few tumors have cells in size that are reasonably to that of a white blood cell or red blood cell, which brings a very mechanistic physics point. If those cells were to clump before we see a metastasis, those cells that do circulate, and this is the first point of what I want to make at, would produce clinical symptoms due to thrombi, and that's not the case. Considering the unknown primaries of about 1/4 of all brain metastases coming from melanoma, we in almost all of those cases, we don't see vascular accidents originating from thrombi, and the composition of those thrombi, even when found, is not made of cells coming out of the primary. And one other thing that I want to point out is this part. The slow growing, which is not the bulk of the cells, but the cells that have the potential to keep the primary growing, do not leave the primary in almost all tumors studied out there. What we find here in the blood is genomic material. And by that, I mean the cells that cross, either those that transform and have the ability to move, to being transformed from epithelial to mesenchymal, if we exclude melanoma, which does not need that transformation. All other primaries which would need that, the problem is that the cells that would reach out blood do not necessarily have the potential to seed, irrelevant of the organ. They do not have that potential because they would need those slow growing radio and chemo-resistant stem cells out there for them to help settle and then introduce a metastasis, which these are two main points to make us believe that more research has to be done for us to find out how do the primary and metastasis communicate. In 1810, it's one of the first papers I've been able to find out there. And Mr. Hauschip, which was a surgeon, published this very nice paper. It's short, but to the point. A case of metastasis or is it a translation of diseased action? He nailed, rightfully so, the terminology of a disease process that we still do not understand. The year 1810, well, he was way here. This visual has two parts. He was way here. And what I mean by that is by the time that Meisner discovered DNA, he was well ahead of Dr. Elizabeth Hay by the time that she introduced the theory of epithelial mesenchymal transformation. And he was well ahead of first use, not only development of make use of next generation sequencing, which was in 2005. From 2005 onward, the second part of this graph shows how much use usually those that have the financial abilities to make use of genomic studies and wide and translational studies being put into the research, but little we know for the process that the primary and the metastasis are able to communicate. Yes, we do collect liquid biopsies. We do make use of the genomic material that we find out there, but we cannot tell if the genomic material by the time that we have collected comes from the primary or it comes from the metastasis. The paradox of the blood-brain barrier stands only for us to challenge in the way we want to cross it and to treat metastasis. If we were to see here, with receptor-mediated transport, large in size and in volume, matters can cross the blood-brain barrier. I used to believe that this barrier holds an enormous power, not necessarily. Through a disease process, which is the metastasis, in general, it holds no power whatsoever to block metastasis. Genomic material, I would not label these as cells, but I would call those a genomic material, either within a vesicle or not, are able to cross. I would not find any scientific explanation of what would be different, if not that the case, for those to be able to settle in the brain. Now, when it comes to the ways we try to treat tumors in nowadays, we have made some advancements. The tumor has gained the ability to use its own antigens, and these antigens are put in between our immune system and tumor cells, identified by our immune system as host, not as an enemy, which makes the tumor cells evade the potential of the immune system. And these are the latest advancements in treatment for us to have the potential to challenge this antigen and to use our own immunoglobulins, our own monoclonal antibodies. Or later, I would show a slide that puts in use the different in between kinases for us to outpass and outrun this mechanism that keeps the tumor cell running and evading the immune system, and have it under the attack of the immune system. Is it possible for us to have it done with every single brain metastasis out there? I would not be able to speak for metastasis in other organs. No, it is not possible. Is it a viable treatment? Yes, it is. The problem is who can afford it? And I speak as a former trainee coming from a low-income country. We are not able even to introduce this to our patients, which mostly would not be able to pay for that, coming even from those that are insured. When it comes to the different steps that a tumor cell has made itself viable and immortal, we have been able in science and through research to have BRAF inhibitors and MEK inhibitors today in use. Those are different steps within the kinase system that make the tumor cell immortal. The problem is that even with those two together, using immune inhibitors or modulators, and then kinase inhibitors, we still are not able to treat even the most or the bulk of the patients with brain metastasis, which tells us that it's a mix of cells within the brain metastasis, which is different from the mix of cells within the primary. And the reaction, the positive reaction following treatment with either or the combination of treatments, a cocktail of treatments, as if to say, when we see that in the primary, we don't see that in metastasis. It's just because there are different steps within each type of these metastasis that we are not able to challenge as of yet. What are treatment strategies that I use? What I see in literature is a use of radiosurgery. And in this case, I want to point out, I'm talking about single or two metastases. This is not the case when there are more than two. The literature has an order of use of stereotactic radiosurgery more often than the rest, and has it used first. But I would argue that if we were to collect that and put it through together, use of stereotactic radiosurgery for those cases where we are not aware of the composition of the tumor, the mutant and non-mutant wild-type genes composing the metastasis would make it difficult for the therapies that would follow. What I want to mean by that is this. I'm not saying the standard of care, but what I often see is recommendation for stereotactic radiosurgery first, and then the other modalities to follow, including surgery. That would create a chaos within the metastasis or even the primary. If we were to follow a scientific logic, I would argue that it is best to start with immune therapy or immune modulators or cytokine inhibitors before radiosurgery, because in not few, but very many cases, we would see radio resistance acquired by the tumor cells, either in the primary, which changes the interplane between the primary and the metastasis, but as well even in the metastasis. Now, those treatments are dependable on most of the practices that are followed in different clinics, but this is what I laid out to my patient, and I recommend them surgery. I find it safe when it's doable, and I find it way more life-saving than radiosurgery when it comes to the outcome in long term. And that's my experience. I should not argue against what data is out there. When it comes to treatment options, we have too many. We have too many, but those have a moderate effect. Now, if we see it's just by half of what we would expect to increase the survival, and that's stereotactic radiosurgery. Immune therapy is not any better when it comes to survival. What statistically that means? We need to do a lot more. It's challenging for low and middle income countries. We might come with ideas for research, but funding is almost impossible back home, at least in a country like Albania, to move forward and conduct research in this field. So when it comes to identifying the primary and then have sample collected, which I would argue then being only stereotactic biopsy, but moving forward with surgery studies, if we find a mutant BRF, we have some therapy which extends life. We have some immune therapy or modulator or cytokine inhibitors that would give us help. Now, what are treatment-related side effects? And before I move on to this slide, the reason I did not stop in details to the long list of therapies out there is just because those studies are conducted in usually separation. There are not many combinations of research work done combining different geographical territories, and this study cannot always apply necessarily to all clinics. Now, when it comes to the following events, these are very common. What not only me, but literature is published. We do see radionecrosis. We do see hemorrhagic coming following not only radionecrosis, but as well immunotherapy. We do see vascular accidents that actually is related with immunotherapy. And when it comes to radiosurgery, we see changes in cognition. When it comes to that point, I discuss ahead of time with the patient. It might happen. And it will happen to if that happens, it does affect the quality of your life. And it is for all of us to discuss that with our patient. Should we recommend it if we have better options at hand, which is in 1 to 2 lesions accessible by surgery? I would go on for surgery if I am to recommend that. Can we spread or disseminate the disease and disseminate the disease? Yes, it happens throughout our course of treatment, either that being by radiosurgery, stereotactic biopsy, or surgery itself. Now, when it comes to surgery, can we predict if following the treatment modalities of what we recommend, we have a dissemination or insemination? And when is that going to happen and to whom of the patients? I see that very often in hemorrhagic and cystic features of lesions. And this is independently associated with the increased risk of postoperative leptomeningeal disease. I see it in stereotactic radiosurgery, and that more often when this outside of the talk for melanoma, but I want to point out, if you have a colorectal or breast primary, you would see it more often coming out of them rather than a melanoma. And when it has extracranial disease, as well as a younger age, that is then when we see higher chances for the leptomeningeal disease to develop. When it comes to the risk of recurrence, it happens with stereotactic biopsy. It is low, but it is present. Now, if it comes for us to put all these steps of treatment, irrelevant of where we are, can we predict somehow of how we are going to do? And if this is applicable anywhere in the world, can we tell our patient by what we have in front of us that how we are going to do together in the treatment steps of our patient? We can tell that if the patient is older, has multiple metastases, has higher LDH, has extension of extracranial disease. In the case of melanoma, that's not always the case, because you would find a brain metastasis originating from melanoma, but not necessarily finding extensive extracranial disease. When it presents clinically, when it's a lesion infratentorial, when it already has affected the leptomeningeal, is hemorrhagic, and at least goes on, we can use immune markers that are very simple, are cost effective, to tell us that how we are going to do with the treatment, and following the treatment if we can predict when we are failing, and to tell in advance our patient that what is next step if possible. Now, if we start treatment and we find results, and these results are meaningful by seeing shrinking, by seeing improvement in clinical symptoms and signs, by seeing changes in the volume of the met, and this is how we can move forward. There are no protocols out there how to follow melanoma brain metastasis, for a very simple reason. Very few patients make it to 2 years, unfortunately. The problem is that at the end of any treatment modality, I would recommend that the patient see us in the clinic. We had a neuro-oncologist that would follow them usually throughout once they move out of the attention of neurosurgeon. But they're back, and now we see them in a month term, usually following any treatment modality for a brain MRI. It's very simple, it's cost effective, and it does tell us a lot. It does tell us, and if a team with some experience has been dealing with these cases in long term, it can tell us if we have radionecrosis. It can tell us if we have tissue remaining following surgery or radiosurgery, and what next steps can we do following that. Now, can we use, and I wanted to bring this point back, liquid biopsies? I would argue not necessarily to be as sensitive as some other diagnostic tools. It depends on what's the budget of the clinic and what the patient can afford. In my country and in most of low and middle income countries, it's impossible to have them asked to conduct liquid biopsies, even for research studies. Not necessarily do provide much information, but if we were to use those, I would make use of those, but only blood, not CSF liquid biopsies, for monitoring disease progression. And I want to point out, when we know the primary, now, is a cure the prevention? I would say yes. I would say yes in most of the cases, but it is not in the hands of only one specialty. It requires cooperation with many specialists throughout the spectrum in medicine for us to make a meaningful change, because the treatment modalities throughout many years of research has made that to be meaningful. The point is that family physicians can be meaningful players in the game for us to prevent the spread of the disease, not only locally, but to prevent the spread of the disease in other organs, including the brain. I wanted to bring those just in case you want to take screenshots out of this talk. These are some, I call it flashcards, statistics, in case you want to have something out of the talk. What I would conclude out of some time I've been working on the research of brain metastasis, and very curious about melanoma brain metastasis. With some degree, we can predict metastasis, the timing of metastasis somehow. I want to point out that the primary and the metastasis are different in many ways, not only in the ways they develop, but even in the way of the disease process, they are different. We have some clinical and meaningful cost-effective means for us to predict the failure or the success out of the treatment outcome. Now, if we were to utilize these differences and the trends that have been noted throughout our work, we can make a difference. We can make a difference by helping patients out there which are not yet diagnosed with a brain metastasis, for them to be free of brain metastasis. And it would require for us to cooperate with a broader specialty other than the neurosurgery. What we see changing from the primary, it does not necessarily reflect the changes coming from the metastasis. We should be aware that this disease is way more common in men. It reaches some point of commonality beyond the 6th decade of life. Well, I must say that throughout this past year of my life, when I took myself into migration and trying to find ways to meaningful training in North America, which I'm still pursuing, I found myself blessed to have had the opportunity to cooperate or work or learn from different researchers. Where I currently am is at the University of Toronto. It's a luck that I've had to be here and use the facilities, I should say, the infrastructure to give me this opportunity. And I'm gonna quote something that I read early morning. I would suggest you read Francis Bacon whenever you have some free time. Wonderful essays coming out of the 16th century. Reading would make us, I would say, a fool, but not necessarily fool. But when it comes to the opportunity for us to share our knowledge and then to write this knowledge and present it in the worldwide, it makes us better. To make me, the point is that I thank you, and truly thank you, all of you, for having me here today. And just to bring a few thoughts in the talk, it gives me a great honor and pleasure. Thanks.
Thank you, Professor Musabelli, for a very comprehensive and thoughtful talk on melanoma brain metastasis. I really enjoyed it. I just general comments. I think you raised a very great point about the location of the melanoma. Anecdotally, I've had a couple of patients with stage 1 melanoma on the arm. They didn't even get extensive treatment after resection. They didn't get any chemo, and they presented with brain metastasis. So I think that's a very good point you raised there. Wanted to ask a couple of questions. You mentioned that we don't pick up the melanoma cells in the bloodstream, and I think that's a very good point. We don't see, otherwise we would see cerebrovascular accidents. What's your thought on CSF as a route of dissemination to the brain rather than hematogenous?
Please, one more time, repeat. What is the thought of CSF dissemination of these cells?
So the tumor cells making into the cerebrospinal fluid and then crossing the, the
blood-brain barrier back to the blood.
Correct.
Well, I put those two slides, and I must say thank you very much, Dr. Mansouri, for you bringing the point in our last meeting about a week ago or so when you talked about liquid biopsies. It's not only melanoma. but throughout many primaries, it's almost impossible to have cancer cells in the blood the way we would like to see red blood cells or white blood cells. It would take hours for us to discuss that. We can see genomic material, yes, out there. Now, the point is, leptomeningeal disease and the presence of the cells in the CSF, it is not as common as the overall presence of melanoma or all brain metastases. I pointed out that the blood-brain barrier, it is not the guardian and the safe holder of the brain. The way that these cells or genomic, I would call it genomic material, either within a vesicle or carried out by proteins, is moving forward and freely in between these interplay CSF and blood and CSF. It is not that common. It is not that common because if we were to see a disease process, leptomeningeal disease is not present that frequently. Now, how do they make it? My understanding is that by the time that we have diagnosed genomic material in whatever form in the blood, we are not able to distinguish if this genomic material is coming from the primary or is coming from the secondary, unless we have distinguished and separated the genomic makeup of the two. Are we able to use CSF? I find it invasive. I am very careful when I have the need to use it in research in general and not in clinic, because it is truly a procedure that unless I have enough investigative information for me to make use of it, I haven't seen the benefits, and I am so sorry. But I want to point out something, please. Let me take one more moment out of the question. I have seen cases, and there has been published in literature, that we do not see until later the presence of genomic material within the CSF, not because it is not present, but because the tools we currently have to identify the presence of those genomic materials coming out of the tumor hasn't been there yet. And how do we know that? If we were to collect data from our bank samples, then we find out, we go back retrospectively.
Exactly, yeah. Yeah, I wasn't quite asking for diagnostic purposes. I'm just curious in terms of the pathophysiology mechanism of spread to the central nervous system. So like recently there was this abstract, I think circulating tumor DNA in triple negative breast cancer in the CSF. It was a high predictor of metastasis to the brain, appearance of brain metastasis. So just a curiosity there.
The list of predictors is simple, it's cost effective, the one that I showed. It is proven to be efficient. Yes, triple negative brain cancer, breast brain cancer metastases have the high propensity to metastasis, but the problem is that not all of those triple negative. And how do they make it? I would say we haven't been able to identify a single, or it doesn't matter the length of the genomic material to be able to be out there in the blood that can move somewhere and settle and then make it on its own to produce a tumor. Yeah. I find it challenging. I see you're very curious on that part. Are you conducting any research on that part?
We're looking at proteomics mostly in the CSF for both gliomas and metastasis, yes.
And what would you think on that part if I were to ask you that question back?
Yeah, my ideal, so as you said, right now it's mostly retrospective. I think it's critical to establish prospective, but I think your point, which is a question I'll get to later as well, is practicality and clinical feasibility. So ultimately signatures are great, but not everyone's going to be able to readily apply it in a clinic. So developing like an ELISA or an other antibody mediated type of test to detect one or two key peptides that are diagnostic or prognostic. I think that's my ideal approach.
If I am to cooperate with a researcher that has the same interest and has the same commonalities in the talk about metastasis, I would say this. I do believe the metastasis and the process and the disease process is a Trojan horse. Why do I think that is the case? We have to have a stem cell originating from the primary, which in almost no case leaves the primary, getting into the blood. we have to have all of these daughter cells, I call it daughter cells, which are different population of cells, getting in the blood. And then we have to have a great team of mathematicians to help us build on an algorithm to tell us by what time and when we do expect these cells to cluster, to cross the blood-brain barrier, and then to settle a metastasis. It's a challenging process, even if we were to make it outside in real life as humans, just to put together these pieces is challenging. How does the tumor make it on its own? I would like to believe that the interplay in between the primary and where is to be a metastasis is well in advance of the time that metastasis is settled. That's why I have moved the research interest of mine from the brain and from the blood-brain barrier to the primary. My current interest are to locate those tumors who do not metastasis to the brain. There are a bunch. I'm keeping those thoughts for myself because I have not been conclusive in identifying the real ones that do not metastasize. I stay away of pediatrics because the cell of origin are different. And I try to keep in my understanding, and I'm going to point out this kind of tumor, sarcomas. The genomic makeup of a sarcoma is more simple than any kind of primary we know out there. It's of one origin, just like melanoma, which is mesenchymal. Why do I keep going back and forth to embryological origin? Because if we have to use lung as a tissue of origin for the primary, it's impossible to narrow our study at this time with the tools that we have, unless we make up few different minds rather than one, because they're not coming out of one cell of origin. If we come off, even if we narrow down to a small cell lung cancer, it is not necessarily the same makeup of the same tumor that we still call it small cell lung cancer, let alone if we broaden out to non-small cell lung cancer, which is, it's a different ball game and would keep us away of being meaningful in conducting research. That's how I see it. I try to narrow it down to just one point. I haven't been able.
I like your very thoughtful approach. I think we should continue that part offline if one day we can.
Please.
So I really like your algorithm of approaching the treatment in terms of BRAF mutant versus not, and immune therapy before radiosurgery or surgery. And
Yes.
Obviously we have good, nice clinical trial data. I think it was a phase 2 out of MD Anderson in terms of immunotherapy alone for small melanoma brain, asymptomatic melanoma brain metastasis. What's your thought on that, immunotherapy alone rather than immunotherapy followed by radiosurgery?
Well, just to cut off clear why I do believe immunotherapy should be first, because we have wild and mutant cells, and those are virgin, those are native, those are naked, their cell environment has not been perturbed by radiosurgery, which would create resistance, would modulate the makeup of these cells, and would hide what was naked for us to treat. And when it comes to immunotherapy alone, I find it way more possible to be the future compared with radiosurgery, but not the case where the tumor is voluminous, hemorrhagic and cystic, because the makeup of these tumors is way different from the bulk of the other types. And I should point out, this is not necessarily melanoma, and it is the future for 2 metastases or more. If I am to give a quality of life of my patients, immunotherapy is as affordable in US as radiosurgery when it comes to 2 or more. Numbers aren't that different when it comes to the end road of treating patient with 2, 3 or more metastases rather than 1 or 2 that are surgically reachable. So immunotherapy is potentially the near future, but not necessarily the long run one. And I must say, I'm scared of radiosurgery. I don't know why. I don't know if this is a personal experience or it has to do with anything that comes out of radiation. I love physics. I do take time of reading and studying physics. The point is that everything it touches, most likely what dies is not always bad. Those somatic cells, excuse me, non-somatic stem cells that make up the bulk of all primaries, in most cases are resistant. It doesn't matter the primary, let alone melanoma. I'm just talking in any primary, are resistant of sarcomas. That's why we see it coming up. Even when we treat with radiosurgery, it doesn't matter the dosage. The difference in dosage and the interval of radiosurgery is just to reduce the side effects of radiosurgery. It doesn't make any difference in long-term treatment. Yes, I see the future coming out of it in near future, not necessarily the long future. I hope to have more data on what is the cell makeup of the metastasis.
I agree. So you presented good data about your hesitancy about biopsies, especially stereotactic biopsy because of seeding.
Yes.
But there's also good data that, and you mentioned yourself, that there's a change in actionable mutations in the primary tumor compared to the metastatic one in pretty high percentage of cases. So in terms of tailoring our treatment, especially now in the era of precision medicine, what are your thoughts on, in light of that, on tissue acquisition when it comes to brain metastases?
This can be done in either country. It doesn't matter if low or advanced country. We can collect tissue whenever possible. The reason that I pointed out is the collection through stereotactics is when it's surgically challenging and you want to avoid clinical complications. When it's more than one, and when with your radiologists are having a hard time to tell when it's coming, when you have one in a surgically challenging or two in a surgically challenging lesions. Other than that, if you have more than 2 metastases, you don't have to challenge yourself. Now, acquisition of data, I would recommend all of us to collect as much as we can. This is not costly, and research can be done retrospectively. The point is that if we know the primary, which we do not in 22% of cases, and that's a very meaningful number, then we can study the primary, acquire as many data as we can, and that's not the case in low and middle income countries. And then guess. This is a guessing, Dr. Mansouri. Why I'm saying is a guess, because by the time that we have a metastasis, a lot of differences are in between the two. Then we guess if we have this bulk of genes that I showed highlighted in blue, chances are that this tumor is going to metastasize. Chances are that the metastasis is going to have this bulk of genes. Of those that we know less than a handful that we can treat or we can target. So the problem is that we need to collect data. We need to share this with colleagues, and we need to see once we start treatment. We started treatment for those that are manned and have been decided to be treated either by immunotherapy or radiotherapy, not surgery. Then we see the progression of disease and the clinical changes as the treatment course progresses. And then we eventually tell ourselves, you know what, this therapy is not working. And why is not working? Yes, we are treating melanoma brain metastasis, but this melanoma brain metastasis not necessarily is equal to all melanomas we know. Yes, it's coming from the upper torso, it's coming from neck, or it's coming from occipital part skin, but it's a huge difference between all those. What do I do in my practice? I start treatment. Halfway through, I do not do any imaging. I just see if there is any deterioration beforehand. I stop immediately. I do imaging and I see what has gone wrong. And this is not for one case, one single or 2 metastases. Usually this is the case in when we have more than 2. When it's amenable by surgery, I try to reach by surgery. And when it is not, then it rests in what it is called trial and error. You try, you see, you try again, you see. I know countries and colleagues that still use chemotherapy to treat patients, and that's what they can afford.
Thank you. Thank you. I appreciate it. Any other questions for Ben?
Dr. Mansour, I need to thank you for challenging me with questions. Thank you very much. I love it. It makes me work. Thank you so much.
I appreciate it.
Well, I think there are no further questions. We can wind this up. We have already exceeded the time. You may say your concluding remarks, Professor Mansouri.
No, as I mentioned, I think even last time I was very appreciative of your thoughtful approach to this, especially whatever we think of, how can we bring it back to the rest of the world, which is the greater population than North America and Europe. So I like that. I hope that we can see a future where, even though I'm a surgeon, we can have less invasive means of predicting metastases, managing these tumors, improving quality of life, and in a way that's relevant to the entire globe's population, not just those that have the means. So looking forward to a bright future. Thank you.
Thank you very much. We indeed had a very, very informative lecture today from Professor Irion Mosabeliu. So I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yukukato. I would like to thank both the speakers of today, Professor Tomita and Professor Irion Mosabeliu, as well as the chairs, Professor Morota and Professor Ali Reza Manzoori. I would like to appreciate all the distinguished faculties for joining in. A sincere thanks to my co-host Liu Bunzen as well as Professor Shubin for broadcasting this on the WeChat channel. And as of now, today we have around 500 audiences who have joined us live. So until we all meet on 23rd, it is bye-bye from all of us. Thank you very much for joining.